Order, order. The committee is back in session. I'm very pleased to welcome Sir Patrick Vallance, the Government Chief Scientific Advisor. Very grateful, Sir Patrick, for your giving evidence to the committee today. And can I first start by thanking you for the extraordinary hard work and resilience that you, as leader of the scientific profession in government, are mounting in this crisis. It is deeply appreciated by everyone. And I'd be grateful if you could convey that to all of your colleagues as well.
I will, thank you. Lots of people will be very hard on it. I'd be grateful to hear that.
Thank you. You wouldn't have heard me say at the beginning of the session overall that the committee, the Science and Technology Committee, as you would expect, will inquire into the handling and lessons to be learnt from the crisis. Most of that evidence will be following the hopefully satisfactory resolution of it. But it's important that we should take evidence on the way, both to capture in real time current views so that not everything is filtered through the benefit of hindsight. And secondly, if there are learnings and actions that are relevant to the ongoing conduct of the management of the crisis, it gives us an opportunity to raise them in a way that I hope that you and your colleagues will be able to find advantageous. So can I start with some questions around the structure of government scientific advice? First of all, one of the things that we don't know is the membership of SAGE, the Scientific Advisory Group on Emergencies. Is there a reason why the membership of that group, which I understand changes from emergency to emergency, but its particular configuration, is there any reason why that should not be in the public domain?
Well, first of all, let me thank you for that. The learning lessons that go along will be an important part of having listening to all of this. Learning about the new virus, so it's important we can look at this very carefully. The members that say, not really a membership, participants of the meeting. So we have the people who come to the table, need to come to the table. They come from a range of backgrounds, in particular emergency, and that is from clinical, virology, epidemiology, modelling, behavioural science, a range of backgrounds. Underneath the table, there are a series of other working groups that have membership that obviously has members as well. So we have a modelling subgroup, a clinical subgroup, we have a behavioural science subgroup, we have those activities. So we perform ad hoc groups as we do with certain requirements. So this is a rather fluid membership without the standing members in the way you have them. So publishing them becomes something that becomes a bit meaningless in a sense, because it depends on any one given meeting, rather than having a standing membership list initially.
Well, it's perhaps I could say it might be meaningful in the sense that many people think it's important that the government should be informed by the advice of scientists during this crisis. Obviously, you and Professor Whitty are visible representatives of science, but for the reasons that you've set out, you draw on the wealth of UK scientific expertise. And in order for people to understand that breadth is appropriately broad and representative, I think there would be an interest in knowing which disciplines and which institutions and individuals are represented and have the ear of you and Professor Whitty and thereby of government.
Yes, I think, as you know, we've now made the documents from SAGE, or medical documents from SAGE public, and the various people who provide the mathematical models are making the models and the code available for the models. So I'm very much in favour of making as much of this open as we possibly can. And I think that is an important part of scientific discipline, important part of how science normally works. I think the challenge is the one of how we get some sort of understanding of all the individuals who are involved in this public is one that I'll take. But I think it's not difficult to say here's a list of members of the state, and the state membership is a thing on time. The only other thing I would say about making sure that our information out, which we will, all our information out, is we inevitably are some very turnaround on key questions. And that very quick turnaround demands them to do things that not normally do. They may revise how to get afterwards. And it's important to don't put methods in place that mean that scientists are coming up with the rules that they need to come up with quickly, which are not like what they would normally have to do. We need to make sure that we get that bit right. But I'm very much in favour of the information that comes to stage is made public and made open up as a channel.
Thank you. I think just to refer to the approach that the committee is taking, there may be lessons on the way rather than just ex post, and I do think some visibility as to what disciplines are part of the advice would be important. Can I ask whether the advice that SAGE brings together and gives to you and Professor Whitty as co-chairs, has that advice been always or usually unified advice? In other words, a kind of consensus view of the group, or have there been occasions in which you've had dissenting views that you've had to put to government?
I think in your previous role, you would have come across enough time to know if you get a group of 25 scientists around the table, you're not going to have the discussion in which everyone agrees every part. And it's quite appropriate. I think it's important that we have it, that we have a challenge every stage of the process. And not all the discussions that we do are smooth and easy. Some actually obvious what the options which they put the others require quite robust more challenge comes in under the question and the uncertainty around the well.
Yes, looking at the evidence that has been published in recent days, quite a few of the papers are headlined, are referred to as consensus statements, and you'll recognise that, and that leads me to wonder: is there an effort at trying to bring together a single scientific view, not in the sense that there aren't different views, but to establish where the main body of scientific opinion is? Is that what SAGE tries to do, or does it set out a range of options for government?
I think what SAGE has to do is to try to take complex science and bring it to a position where we say this is the consensus view of what we're looking at now. But to be clear about the assumptions and uncertainties there are. What I think is not helpful is to say, here is the view, and ask somebody who's less brings together this and try to come to a single view to do that. So we do try to make sure that we come up with a consensus. But we also always clear and purposes about that and the assumptions lying.
In your experience, when such advice has been given, following that process and that principle, in your assessment, has the government followed that advice or gone against it?
The government has listened very carefully to the advice that comes from SAGE, and I think has followed that advice closely. I think it's been really an experience of politicians wanting to hear the advice, wanting to understand the advice, and always having appropriate challenge where there are things that need to be challenged. And on occasion, of course, we've gone back and looked at that again and say and asked ourselves questions whether something needs to be re-looked at. But it's been a process science has been listened to, understood very clearly.
Is there any significant aspect in which the government has chosen to take a different view from the advice that SAGE has been giving?
I think the government has followed I said, listen to the advice of the sage very carefully and follow the advice of the sage. And then clearly there are decisions that need to be made by politicians on how they want to implement that advice, and areas like that are likely political decisions, not scientific.
But there isn't any significant disagreement, you would say, between the government and its scientific advisors on anything material. Thank you, that's helpful. Perhaps you could help us in understanding what you will have picked up and understand to be one of the criticisms, or well, let's say just questions, that the consensus of UK science as reflected in the advice to government and through the published papers has been at variance with what might be described as overseas scientific opinion, principally in Asia, but sometimes in the continent of Europe. How is it possible in a set of disciplines that is global that there can be a markedly different approach that is being recommended in one part of the world than another?
Well, I'm just reminding you what the strategy is laid out for, which initially contained. And I think that was very much the aim. We do in cases, ultimately, contact tracing and consent. And nothing stopping them will effort trying to do that. This became the answer, which by definition means that it is no longer possible everywhere in the world. So that containment phase, which was very successful in some cases early on, before the example, we tried to contain here as part of the good, and I think it's a lot to actually lay these instructions. After that, our approach was, I think, simply the same as the rest of the world, and happened different time frames depending on the circumstances you find. And that's first and foremost, to try to stay in and to reduce the number of people who got infected. That means reducing the overall peak, trying to get that down as far as we could, and obviously critically important to keep that below the NHS ICU capacity. And secondly, to shift it to the right, try to layer it a little bit, and thirdly, to make sure that the most vulnerable people were adequately protected during the time, during the time at which the infection was most prevalent. And those were the principles that we built recommendations around. And I think they are basically the principles that everybody can follow. The question then comes into the speed and the extent to do those at what stage of the outbreak. And we were clear, basically an example of protecting the vulnerable, that the measures that would be in place are obviously quite extreme, and we need to ensure that vulnerable people are protected when the infection is there to be protected from. There's a planning issue there, and there are clearly planning issues around whether to introduce the numerous different interventions that are important and to lay an epidemic. We laid those out very well. Stage first met in January, and we've been discussing this for many things. What we laid out quite early on what the various interventions were that will be needed to try and spread the disease, and through a consensus position through modelling what the likely impact of those different measures on the size of the peak, on the delay of the peak, and the number of deaths. The rollout and implementing that was about trying to make sure that the most impactful, the ones with the biggest effect, were done first and were done properly, and the others were added later. And that's the approach we've taken. I don't think, in essence, that's very different from what many of the other countries have done. It is different from what countries were able to have a very robust containment strategy early on, like Singapore did in that first wave, although of course Singapore is in a different position now.
So one of the differences that one observes from the evidence that's been published, and there is now a lot of the papers that SAGE has published are about particular interventions such as closing schools and about the social isolation of the vulnerable, there is comparatively little reference in the papers to testing and contact tracing, despite the fact that there are some appended papers to the evidence published, including from the Lancet, that suggest that in countries like South Korea and Hong Kong and Singapore, that testing and contact tracing has been the most important early intervention. That doesn't have, I would say, the same degree of prominence in the evidence that is before the public as to what SAGE has considered.
So the first few meetings we had, say, were all totally dominated by the question of contact tracing and containment and isolation and testing. So those were the early factors that discussions we had, and testing brought through examples of being able to do that through Public Health England, and be aware that for a long time the UK was the biggest testing nation in the world now, and we're up to over 90,000 tests now. So testing has been probably on, if not on the agenda, I should think it's been on the part of the agenda to say about testing. At the beginning, it was in the context of testing and contact isolation. Over the more recent times, it's been very much about bringing up tests and making sure that testing is wide level to be able to do much wider testing. And I think that is a crucial thing to do. And there's two types of testing that we're focused on and not discussed around. One is that testing of viral infection itself, and we need bigger numbers, and public health and public health social care has worked very hard to try that testing increase. There are proposals very far and helping to do that. That's very important. The second type of testing that a lot of time talking about is serology testing. So this is the testing for antibodies who had infection. And very early on, we really pushed that that needs to be done through the public health England developed the serology test, and there are others who now got to I've seen the first results of that sort of testing coming through now, and that needs to be ramped up. So I think if that is reflected in the paper, it's certainly very large part of government.
We have changed the policy towards testing in that it was, until a couple of weeks ago, available in public settings through drive-in test centres. It's now reserved for inpatients in hospitals to be broadened to NHS workers. We understand that. Why was it not possible to continue the expansion so that we would be able to cover inpatients, to cover NHS staff and care staff, but to maintain and indeed expand the testing in the public setting of people with symptoms at the very least?
There, at the moment, isn't enough testing to do all the things like we really need to get on with. So, emphasis on that testing is key, and that's why there are proposals to get to 110,000 per day tests. That's what's being worked on at the moment. In terms of detecting active infections, there are measures being taken to put into a big testing facilities around the UK, in addition to public health England testing, and I think that really needs to happen in order to get through. Until we get up to those numbers, then the decision, I think, is the right one. It may test patients in hospital and try to test health workers. And that's pragmatic reality. We can get big enough of testing, the better it will be in terms of being able to test
and is there anything that you think could have been done at an earlier stage to have expanded the number of tests or the capacity for testing available?
Well, I wish we had more tests available today. So, in that sense, it would be great to go ahead of this more than we've been able to do. But it's not easy to ramp up testing for that scale. I mean, it's technically difficult to do. I reiterate the point that the UK was actually the fourth largest sector in the world, but we were not certain around, but it was absolutely the case that we would get many more now, and there's a very industrial sized effort to get up to the large number of getting to. And we need to get them not only now, but also, and this is an important thing to look at, as we go through this, and finally to relax the method in place. Testing is going to be a critical part of that. So, I can't overemphasize the testing right. And then my final point is the scale testing is also critically important. There is a very real problem with things in rush and you test that give you false negatives or positive. And it's important that we do this with the right quality. And I'll give you an example. If you were to test company and get a false negative, you've done a disservice. They then think that they're okay to go around back to work or whatever and cause more problems. We need quality to be right. And that is technically difficult to do at scale. And I know many people very hard to do.
Thank you. So you mentioned the serology test and how important that is to see who might have gone through having the virus without knowing about it. When will that be deployed? You say it's already being tested now. Give us an idea of when we might expect to see the widespread rollout of that and what kind of pace.
The serology is Public Health and Serology working. There's a proposal to do a community-based study of that, looking at the age group, and one of the big unknowns in this epidemic is what proportion of people get asymptomatic infection. There are papers, for example, in Wuhan, that suggest that over 80% of people are uninfected in Wuhan. And there's a paper from Italy that over 70% says they tested for asymptomatic. But we don't really know. So the first priority with the serology is trying to get a handle on that number. We then need to ramp up the testing, and that's where the sort of tests that people have mentioned, a much more self-administered finger prick test that you can do are potentially the answer to that. It's very important that these tests are properly validated, that we understand again false positive, false negative. So the lab-based test is up and running to about 4,000 tests can be done in that per week. At the moment, that's going to ramp up. And the first study will be this community-based study, which we should be seeing results on over the next few weeks.
When do you expect that type of testing to be available at scale across the country?
The tests, the finger prick type tests, are being ordered and looked at now, and if those are effective, I think that needs to be tested to make sure we're clear about the effectiveness and sensitivity and specificity of the test. If that comes back and we can do it relatively quick, I think we need to make sure that we've got the right parameters around those tests before we roll them out. And that's something that DHS and others are looking at now.
The summer or later in the year that we're talking about?
I think it could be sooner than that. If these tests work, that can be done.
I see.
So just to be clear, that is the absolutely desired aim. And if we can put this out quickly, that will make a huge difference to overall testing.
I understand, I'm grateful. In terms of taking the best scientific advice into government and taking policy decisions on that, I wonder whether you can give some clarification from your scientific vantage point on whether people should work if they can work, if they can't work from home, but they can work 2 meters apart from each other. If they're not in a designated critical occupation, providing they can meet that distancing requirement and can't work from home, is it okay for them to work?
Well, first of all, I think I can commend you on being 2 meters apart. I can't quite touch from the front. And I think the aim of the social distancing and other measures in place is to break transmission between households. That's essentially what we're trying to do. You break transmission between households, that allows the whole thing to come down, and you try to get the R value below 1. And the R value is the number of people average by 1/3. And when you get that from 1, that means the epidemic is out of the way. So that's the aim, is about breaking transmission to households. All the measures we want to place, that's one to do that. The best way to do that, of course, is to explain their own houses and what goes on. The work situation makes it impossible for certain types of work and for certain types of essential work, including these others, but many others as well. So the advice is clear. People should stay at home. Home work is absolutely what should be done wherever it's possible to do so. And then there are some situations where it's not possible. And in those situations, staying 2 meters apart is ridiculous.
Will it be necessary, in your view, for people to work in settings where they can distance themselves from each other that may not be listed as critical occupations in order perhaps to provide components to something that is critical?
Yes, I think those are things that need to happen. I mean, we need to keep things going. The health service, now it's all to make sure that this work. But it's very obvious to the doctor, but I'll give you an example. It's rather important that we continue to discover new substances and
Let me turn to Aaron Bell.
Thank you, Sir Patrick. Just briefly on the public health interventions, and essentially it seems that there are a succession of levers that you have, or interventions if you like, that you want to pull. It's just a question of the timing at which we pull those. Is that a fair characterisation?
Yes, that is a fair characterisation, and that's what we're trying to do.
And so are there further levers that are in reserve, or are we now at maximum leverage, as it were, in terms of what we're going to ask the public to do?
I think you heard from Neil Ferguson earlier on, who's one of the more inputting to say, and by the way, we have lots of more, but Neil is certainly we're leading on in this. The measures that have been put in place, the compliance, which now looks as though should be enough to bring it down to a normal overnight. And so those measures, which means at the right time, the right way, should get this below 1. And that's the aim. And I think we look pretty quite, you know as well as I do, really extraordinary measures in place now in terms of the effect on society and the way we live. And those measures, you never say the next page or those measures really should be enough to bring it below 1. And I reiterate, now clear what is below 1. And we should expect with a time delay of 2 or 3 weeks after that getting down there.
Thank you, Sir Patrick. If I could briefly turn to communications, which are obviously part of the strategy, how we communicate that out to the public. Firstly, can I say thank you for your efforts in this regard, Professor Whitty and Dr. Harries. I know it's not a role you sought, but I think you've been very reassuring to the public in your appearances. Could I ask what scientific advice has gone into the overall communication of what we're asking the public to do?
In the table that we published in the page, where we looked at what the interventions were that could be looked at and what effect size they would have, we also have tables describing what the behavioural implications of that were and how these could be communicated from a behavioural science point of view. So there's been quite a lot of work done on that, and very clear as well on behavioural science, a number of different groups which have been given in the government communication process.
Thank you. And obviously we have a free press, but I really would like to ask you what you think their role needs to be in this situation, this epidemic. I mean, is there a case for some sort of agreed voluntary code on how they report on this, given the public health concerns? For example, whether they should be emphasising compliance rather than the exceptions, things like that. I'm asking really for a scientific judgment, not a journalistic one, because I appreciate there's a balance here.
Yeah, I was getting quite close to not being science.
Yes.
You're often good to answer that, and I'm not sure that I can really comment on what papers should or should do in this. But I mean, what I would ask is that papers try and follow the sort of responsible line that's being laid by the government, and it is important to encourage people to be compliant with it. And I think the message that I would like everybody to hear is while many people will get a disease which is mild or moderate, the aim of intervention is to protect everybody. And if we don't do it, if we allow household transmission to take place, then we put other people at considerable risk. And so making sure that these measures are really understood and that people understand the impact of behaviours which don't then allow them to adhere to the I think it's going to cause problems. So I'd like, as always, that communication come out clearly and be supported in the papers. But I can't go beyond that.
No, understood. Thank you, Sir Patrick.
Chris Lance.
Thank you, Sir Patrick. And obviously, I'd like to reiterate the comments about the work you're doing. I think, very trying times. You've actually been very effective. I just wanted to come back to the social distancing piece very briefly. The documents published by SAGE on the 20th of March recommended an alternating period of looser and stricter social distancing controls. Is there a scientific reason for that? Is that better than a single period?
Well, that was one group of modelling that came through the sort of IM process. I think where we are now is very focused on applying these fully, the R1, or we absolutely need to do that. The question, and this is a question that everyone's asking across the world, is once you touch the R1, what is the right strategy to start releasing from that? And you've really got a number of questions there. One of them is to link and monitor, and then perhaps go through the end buttons. The other is to release altogether and things happen, or to release part. And I think that question of can we start taking off these measures and monitoring the effect is one we're going to have to really do, and monitor carefully so we can adjust depending on what we see. But I don't have an answer. And I don't really know what the answer is exactly the right way to do that. And that modelling is one way to do it, have follow-up periods.
Thank you. And sorry, I've got one more follow-up. We're also now following a strategy with the most at risk of shielding, which will involve things like deliveries of food and medicine. Is there any risk of the disease actually being transmitted to those people via food deliveries or medicine deliveries?
Well, there obviously is a risk if the people doing it go into the house and get close contact. So that's why what should happen is that the deliveries should be left in a place where somebody can get them without being exposed into direct contact, if that's possible to do that. And it's clearly important. Nobody delivers to people if they've got any symptoms at all. So I think the measures that have been advised by public government and how to do this should protect the individuals as far as possible and try not to go into practice. And that, in some cases, really in care homes and places where you are going to need to have contact and take the appropriate measures to protect them.
Sorry, just to expand on that, so there's no chance of actually transmitting it via the actual food itself?
The food. The survival of the virus on hard surfaces maybe for 48 hours or so, and then it falls off quite quickly after 24 hours. On soft surfaces, it's actually much less. So that the low probability of using it through food in the way you said, but of course, you've got to wash the right fruit before you use it.
Thank you.
Thank you, Sir Patrick. In the Imperial College report dated 16th of March on non-pharmaceutical interventions, it states that mitigation is no longer a feasible strategy after refining the estimates of likely ICU demand in Italy and in the UK. And it goes on to say that previous planning estimates assumed half the ICU demand now estimated. Given that the government has updated its strategy, the most effective mitigation strategy would involve exceeding ICU demand eightfold. Dr. Ferguson in the previous session said this would now potentially be threefold with the new measures that have been introduced by the government. Does this imply that the previous mitigation strategy still involved exceeding ICU bed capacity by some amount?
Oh, well, there was absolutely no intention to ever exceed the ICU capacity. I mean, that's not the strategy, and that's part of being one. The mitigation, of course, has two parts to it, which define our work. And what we need to do, and what's being done at the moment, is to test the demand side, to try and suppress the numbers as far as we can, and at the same time, scale up the NHS capacity so that it's got the fair needed to do that, and that's what we need at the moment. I can't complete and nobody can guarantee that there will not be occasions when an individual places 5 people you get free. I mean, that's always the main possibility, and of course, in winter anyway, the pressure comes. So there's no guarantee that you can stay within that. But as the various different we've looked at now, with measures in place now, the increase in NHS capacity that's being forecast and talking by the NHS, this looks like being on track to try to stay within that capacity limit, and that's clearly what we need to do.
Thank you. Just to follow up, with the previous optimum mitigation strategy that the government was pursuing, there were figures of how many people were expected to perhaps pass away from the virus. Was there a number of mortality figures that were seen that appeared tolerable, in your opinion?
Well, I think as I said at the beginning, it's difficult to find any strength that they're tolerable. And so our aim from the outset was to make sure we minimise death and suffering and try to make sure that the most vulnerable were protected. And that has always been the aim of what we've been trying to do. Now, there is a course situation that we need to know over what time period occurs. And there's a balance between this going on for a very, very long time or going on for a short time. And there's options that need to be looked at. But I think there was never should be that there's a correlation to death. So one of the reasons for not doing so far, which is what always happens in this situation, trying to say if things are out of work, reasonable case, I can control what the number of deaths and the number of infections you end up with. And that's the reason the worst case scenario we've spoken about in the past.
And just to very quickly finish, Dr. Horton just previously mentioned warnings that were coming out of China before the World Health Organization officially declared the pandemic on the 11th of March. There were also warnings that if the virus spread beyond China, it could become a global pandemic. This was around January. Given that, what was the reason for the government's delay in seeking the resources it needs to deal with the pandemic? For example, leaks to journalists only this weekend show that a senior Downing Street aide wrote to research institutions asking to make use of their testing equipment.
I'm not sure I'll answer the second part, but I'll answer the
So,
first part.
only this weekend there are leaks coming out that Downing Street is requesting access to use testing equipment.
Okay. Yeah, so this is about testing scale up, and clearly there are bits of equipment all over the place in the UK, and the question is whether they can be utilised in some way which then gets to the industrial scale of test. So that's not entirely appropriate thing to try to do. In terms of the indications of the pandemic, very early on, and I think the CMO put this very well, there were really two things that happened to China. Either China contained it completely and it would have gone away, and that was one possibility. And the other was they wouldn't contain it, it would spread and it would become pandemic. And early in January, it wasn't clear which of those was going to be the case. And as things have gone on, it became clear, I think in January, that this was happening in a location where it would infect China and it would spread. The official declaration of the pandemic by the WHO is obviously in their hands to decide when they'll make that decision. But by then, of course, we were planning absolutely that it was going to go across the world and already see it spread in a number of places. And I spent time, and Chris Whitty spent time making sure that we spoke to our colleagues in other countries to learn what was happening there as well. So I think that spread of the pandemic became inevitable at some point during that time. Probably before the WHO declared it back then, it looked like it was in that position.
Thank you.
Patrick. Zara mentioned Dr. Horton. In his evidence before us this morning, he wondered whether there was sufficient clinical representation on SAGE. Can you clarify that for us?
Well, rather unusually, both the government chief scientific advisor to me and also the CMO, both medics, and we also have the NHS medical director on SAGE itself. So we have a number of clinicians around the table, including also from Public Health England. So we've got quite a proportion of SAGE is actually clinical, but there is a clinical subgroup that feeds into SAGE, which has all clinicians on it, do a lot of the work that then comes in on the clinical aspect. So there are lots of people involved in the process of second stage and important part of consideration. And it is crucial because the modelling is one form of evidence. The real understanding of what it means to be in the hospital, clinical, to have patients in front of you, and the different layers of it. And it's why the makeup of SAGE is so important in the different disciplines we have around the table.
Thank you, we're grateful. Mark Logan.
Yes, Sir Patrick, just some questions around the science advice to government, and just want to understand a little bit more about why it took until the 20th of March for SAGE to publish the evidence informing its advice to government.
So SAGE historically has never published any of this information until afterwards it publishes things, and so this is a departure actually. It's one thing I personally welcome. I think it's important we do get the evidence out there. It took us a while to get it into the right shape, get it out there, and get the permission from people because we're reliant on the papers and the information that come from contributors to things, and that's their proprietary information. Everyone talks very quickly to the public, and I think that is a change to the way SAGE has worked historically, and one I personally welcome.
And finally, who took the decision to publish this evidence from SAGE?
Well, it was taken by me as a go SAGE leader.
Great, thank you.
Thank you, Mark. Just reflecting on the evolution of the approach that we've taken in this country. I mean, it seems to me, reading all of the evidence that's been published, that it really divides into two phases. The first phase was a belief or an assumption that most people in the UK would contract the coronavirus one way or another, and a certain scepticism of what might be called the Asian approaches. Looking at the paper of the 26th of February, for example, the potential effect of non-pharmaceutical pharmaceutical interventions, the paper, the Sage paper says, implementing all the measures, the suppression measures, would result in a second epidemic once they were lifted. The paper of the 9th of March, the potential impact of behavioural and social interventions, says that implementing a subset of the measures would be ideal. Whilst this would have a moderate impact, it would be much more likely to result in a second wave. In comparison, to reduce the second wave, in comparison, combining stringent measures as a long-term policy may have a similar impact to Hong Kong or Singapore, but this would result in a large second epidemic once the measures were lifted. So I discerned that. Then there was a shift, and a shift to suppression. We've obviously had evidence in person from Professor Ferguson and of course his colleague's famous study showing the capacity of the healthcare system. That is obviously one very important reason for that shift. Is that the reason for the shift? And was it not possible to have accurately modelled the balance between the demands on the NHS and its capacity to supply intensive care unit beds earlier than in March?
The figure of most of the population becoming infected was the reasonable worst case scenario, and that was derived from what the constrained epidemic would do, and the figure of 8% is the upper figure you get to if you have an unconstrained epidemic. So that's basically what you have in the epidemic, the unconstrained upper figure. It wasn't a prediction of what would happen. And of course, wherever you look at this, it doesn't look like anything close to 8% of the population becoming infected. So that was a reasonable worst case scenario. We were concerned, and remain concerned about the second wave, and of course that was quite a feature of, for example, the 1918 pandemic, pre-pandemic. The second wave caused more deaths than the first wave. And so the second wave is something to remain concerned. And the more likely, the more you suppress it down to zero early on, the more likely you are to get the current response. So this is a very difficult thing to try and balance. And what we're trying to do is get them below the ICU, keep them there, allow some release of those measures, and also for treatments that are being looked at, and vaccine hopefully will come along one day. But we need to make sure that we allow the ICU numbers to breathe. And the model that Neil Ferguson and many others did right from the beginning has made that, I think, with the range of possible outcomes.
We've taken evidence today that a vaccine is unlikely to be available before 12 months, and I think you've said much the same. There was the outside possibility that it might be 6 months, but that was an outlier rather than something that we could rely on. So if we are to be suppressing in the way that we are, without a vaccine, are you anticipating a second wave later in the year?
I think that goes back to the answer I gave earlier on, that one is true across the world. It needs to press, and we need to start relaxing the indicators with what's happening in many countries. We're now in the process of trying to keep our value below that. As we release those measures, we're going to have to monitor very carefully what happens in terms of an increase in infection. You can see that happening basically increased number of infections now occurring, having very successfully contained it early on. That's going to be something that we have to measure as we go along. I don't know for sure if we can make the result of that, or we can say on this one, that's one thing we've got to be very concerned about, something to keep an eye on, and I think we can't do anything now other than suppress and then release those and not indeed that goes.
I see. Shot through the early papers that have been published, is this great concern about a second wave in the winter, and obviously the capacity of the NHS currently to absorb critically ill patients has been very, very influential in determining the change of approach. But I haven't detected any revision of that concern and anticipation of a second wave. And I was struck by one of the papers published in Evidence, paper from the SPIB group, Insights on Public Gatherings, published given to the committee on the 12th of March. And what that advice to SAGE said was that acting in a way that does not meet expectations poses a risk that a section of the public will view government actions as incompetent or not in the public's best interests. SPIB has pointed out repeatedly that trust will be lost in sections of the public if measures witnessed in other countries are not adopted in the UK. So can I ask Patrick, to what extent is the adoption of measures that have been adopted by other countries complying or driven by compliance with that advice of SPIB, that we need to be seen to do that for public confidence, or to what extent does it reflect a change in the very solidly argued early assessment that we must act to prevent a second epidemic?
Well, there's several questions up in that one. On the point of procedures, we laid out what the measures are that we do early on, and those measures need to be implemented at the right time, and that's the part that we do. Mass gathering was one of the very early ones that caused quite a movement because it was an easy one to do. And you could see several people going early to watch mass gathering. The point that we discussed, and I think it's laid out in the paper, is that banning mass gatherings alone is a very ineffective way to try and stop this problem. And that's why we shouldn't do it early. We need to things that matter early and concentrate on getting those things done early. We also say that mass gatherings are part of a broader social distancing program where you're also talking about smaller, more intimate gatherings that do spread more readily, would be a sensible thing to do. So mass gatherings actually only came in at the time that we were also dealing with other types of gatherings in greater social. And that was the reason that mass gatherings came in at that point. The second part of the question.
So the mass gatherings was an instance, but the point of that paper that the committee, that the advisory SAGE took, was that the advice was that we should take measures that other countries are doing, because if we didn't, there would be a fall in public confidence. And so what I was getting at was, are we taking these measures because others are doing it, with some private scepticism continuing, as you evidenced before on this? You know, it's if you can't beat them, join them kind of approach. Or is there a reappraisal of the actions that are needed?
Well, none of those. It's that we laid out all the measures and said, as we monitor the epidemic, you may need to work through those and pull all of those levers. And all of those levers have been pulled. Well, not all of them, I mean, there are other things you could do, but the levers have been pulled to get us there. So it was a tightening thing, and the reason that it became necessary to enforce compliance more to this is because without good compliance, it didn't look like we were getting numbers down below the ICU capacity, and therefore we had to do that. So it was not in response to what others were doing and saying we need to do like them, following the trajectory that we put out, implementing those policies, making sure we
compliance was, and when we saw that compliance was enough, that was the question, what needs to happen to compliance greater, and that's
Thank you. I'm grateful. And finally, just going back to testing and the rollout of new tests and making that more widely available, is that now an operational matter for the government and the NHS, or is it something in which you and your colleagues in SAGE continue to have an important role in setting policy on?
No, it's largely an operational matter. It's certainly a matter that we continue to look at because it's so important for the approach to being able to monitor this going forward and release the measure. It's an operational.
Thank you. And in Professor Ferguson's evidence, he gave some comfort that the capacity of the NHS, with the measures that have now been taken, is likely in aggregate to be sufficient, which is obviously important news. Just finally, as a kind of wrap-up, can you give the committee and those watching this a feeling for what length of time you would expect the current measures to be in place and to have a significant effect?
If you look at what's happened in other countries, if you take the measures that we've taken, you start to see a change in terms of the R value within 2 weeks or so. If you measure ICU patients for maybe 2 to 4 weeks, and as I said, difficulties are now at the low time and they're almost down. I'd like to give you some indications of timeline, not scale. The scale is communicated with different countries, the timeline over which you start to see this coming down. But getting it under control, doing hard work one, and the epidemic goes down, I think you can see follow that sort of number. Then the question is the important one is what can you solicit to allow this to go forward? How do you monitor that? And which ones need to stay in place longer than others in order to achieve what it is? And this is only starting now in China, where measures are being relaxed. Apparently, we see what happens in terms of the disease and the outbreak. And I can't give you an answer to what happened there. We observe and we need to think about what we need to do here in response.
Sir Patrick, thank you very much indeed. As you said much earlier in our discussion, my experience of working with scientists and indeed yourself in government is that science often does involve disagreements and arguments, and in fact that's the way it proceeds, testing hypotheses. So that is inevitable. I feel sure that having observed the structures that we have, it is a good thing that we have people of your calibre and supported by others advising in government. This is a time, we know, of great work and pressure on you. We're very grateful for your public service during this time.
Thank you. And I'd like to take this opportunity to thank the many, many scientists who input into this work and have worked day and night to try and get some of this information available. I'm extremely grateful.
Thank you, Sir Patrick. At the beginning of the session, we conveyed similar thanks, and I reiterate it now through you. Thank you.
Thank you.